also an honor because, you know, much of what I've learned, I've been reading. I'm meeting for the first time some of the authors of papers I've read over the years on this, and it's especially, and some of the people here have encouraged me many years ago to get into this area, and so it's really quite an honor to get to present back. And as you know, all this really started in Europe, in the German countries. So I'm going to be presenting on my paper in the results, the data from this on this lipedema reduction surgery, and these are tell you a bit about this. These are it's with tumescent anesthesia with maybe a little bit of oral sedation, and these are large volume liposuctions. So the average volume was a little over 5 liters, but my maximum volume aspirate was 13 liters. We did follow hemoglobins, and we had a very small, only a small percent, less than 10% had any drop in their hemoglobin. I attribute this lack of blood loss to having the veins treated beforehand, and also I also attribute it to very robust tumescence. But I also think the tumescence also helps protect the lymphatic structures. So this was the first surgery from the U.S. on looking at outcomes from the lipedema reduction surgery, and we looked at knee joint mechanics or gait inflection, and then we also used outcome measures, patient-reported outcome measures, and we were able to correlate these mobility gains with life expectancy and future disability. And many of the objective measurements are also used in orthopedic literature, and they're followed they follow that pre and post total knee surgery or knee replacement. So here is on the far left there, this is measuring the angle of the knee joint. It should be a straight angle, but in lipedema patients, there's often a valgus deformity or knock knee, and this is previously noticed, but we combined prior to surgery the measurements and after surgery, and you can see in this middle picture we're measuring the knee flexion. This target light doesn't work so well, but the I'm just gonna, so a normal knee would be here, you know, would be 135 or more angles of flexion, and this is a lipedema lady, and you can just see just the extra tissue in the back of the calf and the back of the thigh that limit the knee flexion. And so we were looking at you know, these measures, these measures here. So we see that there's about a 10 degrees improvement in knee flexion. So our average lady started with 120 degrees of knee flexion and improved to about 130, and that's both the left and right knee. And there was so they had a correction of about 3 degrees in the valgus deformity. So they started about in the middle two slides. You can see that they started with about an average about 6 degrees of angulation of the knee joint, and it improved to about 3 degrees. We did also look at the Q angles, and they didn't change significantly. We also measured their gait, and about 80% had an abnormal gait before surgery, and that improved to about 80% with a normal gait after surgery. So this knee flexion is really critical for many movements. So if you don't have if you don't have a full 135 degrees of knee flexion, you're going to have trouble getting out of a car or getting out of a bathtub, and actually even around 120 degrees obviously affects running and can in descent of steps. So it really can impair mobility just by the physical obstruction of the range of motion. We also looked at this. There's a promise is an NIH developed toolkit to look at patient outcomes. It's been widely validated to the population. So we're looking at normal people in the population would be 15%, and their mobility score. And then we looked at, and so your pre-surgery, my average patient had a mobility score of around 37, and it improved to about 45, which is a significant improvement, closer to normal for our lipedema patients. And then we also, so on these mobility things, they had a 16% ability to walk at a normal speed, a 16% improvement in the ability to go up and down stairs, 27% improvement in the ability to run a short distance. Now these measurements that I just showed you, they have also been studied, and so the ability to walk certain distances without difficulty, et cetera, is correlated with actually future life expectancy, and it's also correlated with decreased risk for full disability. So these are powerful improvements that can that this clearly shows these are in their daily life that are it's more than just the improvement in pain. It's also these outcomes are associated with greater life. A little more about the surgery. All of them were started with compression and nutritional counseling. Most of them had decongestive programs and had counseling on an exercise and either to lose weight if they were overweight. Now, just these conservative measures, which were used for all these patients preoperatively, has been shown to decrease limb circumference and pain. But they, and I actually did previously published on that, and these same things did not improve overall mobility or knee mechanics or have the kind of improvements, the significant improvements in the patient's quality of life when surgery was added to these conservative measures. Then looking at these SF36, there was a 12% decrease in overall body pain. And then we looked at the eight domains of health on the SF36, and all of them were significantly improved from overall physical function to role of emotional limitations, energy and fatigue, etc. And overall, they rated their overall health improved as well. So there was a 12% improvement in overall health. So all 11% ability to handle activities of daily living, and a 13% ability to complete tasks which had previously been limited by pain. And also an improvement in the ability to complete tasks limited by emotional problems. So, again, these were large volume liposuctions, and in our stage 3, or our lipedema patients with lobules, there was a significant decrease in the number of lobules. So with thigh lobules, there was about 80 or 90% had thigh lobules pre-surgery, and it reduced to a small percent after, and then that's on the inner and lateral, and then knee lobules, also a significant decrease from around 60% to less than around 10%, and then in the upper arms also decreased. So this is just liposuction on the arm, pre and post. This is the post picture is about 6 weeks after the liposuction. This is just a before and after, the before on the left and the after on the right of someone who's had 3 liposuctions. And this is an example of the knee lobule that pre and post. So I believe this represents a regression of the stage of lipedema, because if lobules to me is the most important criteria for deciding between stage 2 and 3 lipedema, and so I think also we can say it can link to regression of lipedema stage. Yeah, thank you very much for this.
Thank you very much. Are there any questions? Yes, Michael.
I would have one simple one. Has there ever been a comparison of the movement range of the knee between obese people and lipedema people? So, in other words, can we differentiate simply by the range if we have an abnormal fat deposits available, or is it just obese people?
Well, that's a great question, and so I mean, obesity is many things. It can be all abdominal, and they can have very skinny legs. But what affects the mobility or knee, certainly the knee flexion, as you can see, is really the bulk of the tissue. So a lipedema leg is going to have much more bulk in the back of the thigh and in the back of the calf, and that's going to have a greater effect on mobility. But certainly, if you're obese and you have a lot of obesity fat in your legs, I guess that too could also work that way. But generally, again, the metabolic obesity is more central.
Any other questions?